So, hello everyone. Welcome to the Pharmacy Operators Podcast. Today we have on Scott Hughes. Scott, do you want to do a brief introduction?
Sure. Hello. It's nice to meet everyone. I'm Scott Hughes. I'm VP of Strategy here at CareMetx. I've been in the healthcare industry for over 20 years in roles within operations, within sales, working both with pharmacy clients as well as working with biopharma manufacturers as well.
Yeah, so for those of you who don't know, CareMetx is a specialty pharmacy hub. They do things on the pharmacy side, on the medical side, and what they help with is a lot of aspects of that, paperwork that is complicated and hard for providers who are dealing with these specialty medications. And Scott, his unique background, which is super interesting, is kind of different companies that have all touched different aspects of the workflow when it comes to medications. And so what we're really excited to dig into is his experiences across these companies and what he's seen evolve in sort of infrastructure, in technology, in different areas of how different companies have attacked the space and really made it better and faster for patients to get on therapies. And so diving right in, you spent time at a company called RelayHealth, CoverMyMeds, Phil, and now CareMetx, all on the connectivity side of specialty. So they're really looking at, Relay was doing the infrastructure for how prescriptions ran. CoverMyMeds was doing prior authorization connection between a doctor and a payer. Phil and CareMetx are more on the hub services side, so they're dealing with pharma companies and helping, patients get on therapies quicker. For listeners who aren't deep in the weeds, what do we mean when we talk about the plumbing behind specialty access?
Yeah, no, it's great, Eesha, to kind of talk through the plumbing aspect. And so, if you think about the process of a script or an RX order starting from the provider, right, as you get prescribed a certain treatment, that starts with the provider, but then ultimately ends with the product getting dispensed to you or getting provided to you, maybe even at the provider's office. But the plumbing is the inner workings of what helps that script or RX order get from that provider's decision all the way through the product being dispensed and then you getting that treatment at the actual pharmacy or even like at the doctor's office. So the plumbing is all of that, the connectivity, the systems, the way that an RX order comes into, say, a pharmacy entity or a hub, and the systems that are being leveraged, and then connecting those systems, that hub or that pharmacy, downstream to how the actual prescription then is dispensed. And that plumbing is all of that process that takes place between the provider and the actual dispensing of the script.
Why is specialty access so uniquely complex compared to retail or traditional pharmacy?
Yeah, so first of all, it really comes down to cost. So ultimately, when you think about a script in the retail or traditional setting in a prescription, that is usually driven by it's usually got a smaller cost associated with it. And when I say smaller, we're talking anything that's probably a couple $100 to maybe even that's more than $1,000 as far as per prescription that you would get
Mhm.
at the retail. When you have some of these more complex molecules, there's usually a higher cost to that medication as well. Hence, that's where specialty access comes in because now there's more, rigorous requirements from the payer before they actually pay for something that has a higher price tag associated with it. If you think about it in the plumbing term that we were just having, Eesha, which is, right, you think of retail as more of that, maybe the traditional maybe toilet at your house, right? That you have just kind of the normal regular toilet process, right? That's retail is just kind of that simplistic approach to that, just a regular old toilet. We think about probably specialty if we use the plumbing aspect. That's probably having more of the plumbing associated at a hotel of how the inner workings of having the commode work across, entire rooms and the entire hotel organization. That's probably how you would probably take the analogy from a specialty access perspective. So try to utilize that plumbing access, that the difference there in those systems. But a lot of that's all driven by the cost of the medication, which would put something with higher cost into more specialty access.
Mhm. And so, Well, how does the cost factor into this? Is it because insurance gets complicated here? Is it because now there's like more decision making about who's paying for it and they need a lot of documentation? Is that really where it's coming from?
It is. So ultimately, when the higher cost comes into from a product perspective, you now have higher scrutiny from the payer. Payer is going to have a lot more validation steps or prior auth or step therapy requirements, depending on what's out there as far as therapeutic equivalents, generics, things like that as well. But ultimately, that higher cost of that medication require more steps that the payer needs or requires so that ultimately the actual prescription can get approved. And those additional steps then what leads us to having more of the operations side of getting access for that script, having solution sets, having a hub to be able to work through those processes that a provider or sorry, that a payer that would require. Working through that is what actually ultimately is where the cost is. But a lot, like I said, cost is what's going to drive the payer to put a lot of the steps in place, the prior authorization, a lot more requirements to getting the actual coverage of the product.
Yeah. I think one thing we found really surprising is we were talking to a few folks that work with hospitals on their
Mhm.
specialty pharmacy sides, and typical hospital pharmacy leakage is around 75%, so they retain about 25%, which sounds crazy, but really it's because of the payer complexity. Like payers just don't allow the hospital to fill it, it has to go outside. And so now you've added this complexity to the step where it needs to get rerouted somewhere or it needs to go somewhere. And there's many different times, it's not just hospitals that experience this, it's other practices too, where because of what the payer is dictating and where the care needs to be managed, you now have to do something complex in order to get the patient on the therapy.
Yeah, I mean, to even add a little additional layer there, you'll ultimately see that depending on the product and the way that the payers react to it, it may be something that's more under the more major medical for the patient's insurance rather than the
Yeah.
pharmacy benefit. And that in itself adds more complexity and more of the reason why you need these additional solutions, services, hubs involved, because the way the payer wants to pay for it is it's going to be under major medical instead of pharmacy benefit. And that in itself creates a whole nother element of
Mess.
things that need to take
Yeah.
place, other hurdles that need to take place, where the product can actually be dispensed, right? Like you were just kind of alluding to from an institution and hospital perspective, a lot of that's driven, once again, all by usually the payer requirements that ultimately then that flow down to how the actual services need to be aligned for patient support to get the patient the actual access of the script.
What part of the process today still surprises people in terms of how manual or fragmented it is?
So I think there's two pieces here. I think one, the intake process today is still relatively manual. With a lot of different brands today, and a lot of way that the provider starts support for these complex medications, a lot of times there is still this element of doing a paper enrollment form, downloading it, filling it out manually and then faxing it, right? I said fax, but faxing it to the actual hub. And that is interesting. We live in 2026 now and we're still talking
Mhm.
about fax, right? Rather than talking about, an electronic prescription or electronic means, we're talking about fax. So I think that's one area that's still kind of surprising that it's still outdated, it's still manual, and it's still creating a lot of work in the process by having that. I think the second thing, Eesha, is probably on the data side. So today, a lot of what's taking place when it comes to getting the data for a program. So think about the manufacturer is the one that's going to is be interested in the data of the process. So of providers sending the script all the way to dispense. The manufacturer wants to understand that patient journey, the entire process to understand how long a patient's waiting, what's happening with prior auth access by payer. The problem is a lot of that data is fragmented and not synchronized from a patient level perspective. Part of that's because it's actually coming from multiple systems or multiple companies that are supporting the patient journey for the brand. And that's why we even have companies that are called data aggregators that help to kind of pull the data together and then ultimately provide this picture back to the manufacturer maybe a day or two after the patient has probably gotten their medication. But that part is still very fragmented in our process today.
Yeah. I think what's I told I forget who once, but the number of faxes in healthcare is about 9 billion per year, which is an insane number to think about.
Yeah,
That's like 9
faxes,
billion faxes where someone has to look at
right?
this document, figure out what to do, and like,
Right.
it's pretty crazy. Yeah.
We shouldn't be talking
Uh,
about faxes. I mean, if we can go from paper scripts to e-prescribing, right, which is something that we went through, we
yeah.
should be able to now be done with faxes. I'm not really sure why we're still using faxes, but hopefully that's something that we'll see go away, in the coming years.
Yeah, hopefully. So during your time at Relay Health, we saw the emergence of electronic prior auth. Some level of benefit verification happening electronically and payer connectivity. What problem were those early systems actually trying to solve?
So with those early systems, you were trying to basically speed up the process of getting a script approved, right? Getting the actual patient on therapy faster. Um, I remember when I started because I worked in the pharmacy initially. I spent 10 years in the pharmacy. In the early 2000s or just before the early 2000s, you would actually have a lot of what was known at the time as a lot of cash prescriptions. You didn't really have insurance companies paying for a patient's medication. You had a lower cost too, but ultimately patients would come into the pharmacy and they would pay cash for whatever the script cost, whatever the medication cost. The rise of insurance then and that connectivity then led to now having more third parties with the way that they would structure how a script would be covered and what they would pay for versus the patient's responsibility. And if you think about how that process has continued to grow over time, when you think about the connectivity, you think about the BV process and the prior auth, a lot of what that's doing with that emergence of trying to basically communicate the billing aspect and coverage aspect for a specific script, those services are really designed to really help speed up getting the patient approval and that communication with the payer so that ultimately you've got an approved script and the patient's not waiting maybe a month. Instead, they're maybe only waiting a few days to actually get the actual coverage for their script.
Hmm. When you moved to CoverMyMeds, how did the industry expectations change? Was it still about kind of solving, getting something submitted or information, or were pharma and payers suddenly asking for more?
Yeah, so when I moved to cover my meds, it was always still about how do I solve the actual prior auth process, but the manufacturers moved from just the transactional piece of PA happening and claim happening as far as a billing claim happening to then now how do I get and I kind of mentioned this earlier, how do I get more data? It became more about the data aspect. Can I get
Yeah.
data on each payer? Can I get data on what their denial reasons or what's happening with the rate on which they actually approve a specific their specific brand, right? How quickly is that happening? That data element was something that kind of grew over time, that it was no longer just about supporting the patient from an affordability perspective or getting them access. It's now about how do I get more data on the individual transactions coming back from a payer perspective. On the flip side, from a payer perspective, payers are continuing to try to figure out how do I basically now understand what's happening at specific pharmacies? How is it happening specifically? How do I get more insight from on the rebate side, right? Of trying to make sure that the rebate information is there. And so that's where kind of that grew from an expectation from a payer perspective when I'm working at CoverMyMeds. So you can see that aspect on the payer side.
Interesting. And I guess hubs emerge kind of as a response to the gaps in data, and also in the gaps in terms of like fragmented workflows that were happening that caused patients to slip through the cracks. And so hubs were like an interesting entity that were really, you know, kind of like finding this new category where they could play. In your view, what problem were hubs originally designed to solve, and what problems did they actually end up owning?
So I believe that the hubs were really designed to help with completing the steps for access, right? So they were ultimately designed to say, how do I get the different BV information, or how do I basically step through prior authorization and get that information collected to get the patient access, right? And so as manual as that process sounded, ultimately the request would come into the hub, and the hub was designed to then work through getting, you know, what is the payer going to do from a coverage perspective? So what is the patient's coverage? What is the coverage? What are the requirements needed to get this patient covered? And then working through the steps to get the provider what they need to be able to then finalize approval with a prior auth and the payer. That's really what they were designed to do. I would say where you kind of see that, what they're kind of left with becomes more of maybe the affordability side of things, and trying to make sure as a patient is working through coverage or not, or if they have coverage, not coverage, where they fall as far as their income level and what they can afford of the actual prescription, whether it's through insurance or not having insurance at all. It's more of the affordability of how do I get that patient now on some form of coverage, whether that's now moving them to patient assistance or some form of copay program, bridge, quick start, those types of programs. And I think it's more now of helping that patient on the affordability side is what they're kind of left with now, more so than anything else.
Mm. I think if you think about the core workflow, enrollment, benefit verification, prior auth, financial assistance, and then finally dispensing, which step has improved the most and which has barely changed?
Yeah, so I see this is probably something a lot of folks already know of, but I would believe that BV and PA support have adapted to the artificial intelligence and leveraging that technology so that it's less about a phone call, it's less about an email, and it's more around utilizing the electronic network and infrastructure that incorporates artificial intelligence to easily find and retrieve the benefit information, and then utilize a lot of that same way technology and same artificial intelligence to help create, populate, and submit the actual prior auth. So those two steps have really, I would say, drastically improved, and maybe probably mostly improved maybe in the last 5 years, 6 years.
Mhm.
And that's really the area that I'd say has improved the most. If I look at what hasn't really been approved a lot, it's probably one would be the financial side of things, financial support. And if I'd add number two, I probably would go back to the enrollment side of things. But I would add that as two because I think there's still some of the leveraging some of the electronic prescription aspect and e-prescribing to start a patient's journey has at least cut down on the faxes we were talking about earlier. But the financial support is probably an area that I think needs a lot of work. What we notice, and working here at CareMetx, what we have noticed is that a lot of the foundation and PAP programs out there still leverage a lot of phone calls to get on cover it or get the patient the therapy, the free goods therapy. And that process, unfortunately, is less and less tech. When we talk to clients today and their foundations, we're seeing a lot of less tech and more headcount. And the problem with that is headcount really translates into a lot more manual process,
Yeah.
right? We don't want to take away from the human element of working with a patient that needs it the most because they can't afford things, but we still want to make sure that we're the fiduciary in the right way, that we handle the resources that a manufacturer has and utilize the technology the best that we can And there's a lot of technology, like I was just alluding to with BV and PA support, that can be leveraged to really improve that process. And so I think that's an area that really still needs a lot more work, that is still very manual, that probably is as much as manual as it was 20 years ago.
In terms of going from, we have these infrastructure platforms set up, we have different services set up. All of them are kind of gathering data in some kind of way. Where does data tend to break down today? Is it on the payer side? Is it on the prescriber side, pharmacy side, manufacturer side? Or is it just some kind of trust issue between people where they don't want to share things?
So it's interesting in your question. In your question, you kind of almost just siloed it, and that's kind of almost how where I'd start this kind of response is it's siloed. And so today you have different companies and that have different systems that handle the provider side of things. There are, ways that the e-prescription connects with the pharmacy to send the RX order, or they may be using some other type of platform that's integrated within their EHR practice management system that helps digitize an enrollment form. That system is one system that ultimately the manufacturer at the middle of this wants to get the insight and get the data from. Then you've got the pharmacy capacity or component, where the pharmacy has its own element of tracking the BV and the PA results and that information that's happening with the pharmacy. And then you mix that with a hub that's trying to track patient cases and case managers understanding where the patient is in their workflow. That's in itself another silo. And then you've got potentially the SP that's doing, the dispensing, whether that's a true dispense that they then send to the patient or a white bagging scenario. But ultimately, you've got them as another silo of data that ultimately this fragmentation is created because you've got multiple companies, multiple manufacturers that somehow then now have to feed in a synchronized way to provide the picture back to the manufacturer so that they can run their operations more efficiently. They can let their field team know more insight. But that siloed process today is the biggest challenge, is that I would say that there's not a trust issue. I think the trust issue, I think we're past that. I think we actually have, I think the regulations are in a place where we can easily get the interoperability and the sharing going. I think the trust is not an issue. It's now having the infrastructure to be able to connect the pieces. Little plug, but what CareMetx has actually done something in this space to actually help feed this information and help synchronize the information at a near or real time aspect for the manufacturer, kind of cutting down the latency and then cutting down the ability to kind of connect multiple systems. CareMetx has built a platform that connects all of these systems to one place that then connects into the CRM. That way you've got all of the information kind of coming into one place and you're not left with these silos. It's all one place that ultimately feeds back to the manufacturer. And they're getting these updates real time. They're not waiting from a data aggregator to send this, a day later or 2 days later. So there's more things that the manufacturer can do operationally having this all together.
Yeah, makes sense. I guess in terms of the true interoperability aspect, from your stance, it's not technical, it's not regulatory, it's really just making that, I guess, investment into the infrastructure like you guys have done to make it happen.
Correct.
Is there anything else you think is still a barrier to it? Is there anything that blocks it today?
I think right now it is more awareness, right? What we find as we have conversations with some of the enterprise biopharma clients and thinking about some of the larger biopharma clients that have kind of an in-sourced or internal type of CRM rather than contracting with another company for their CRM and then having that system. Right now, it seems like awareness is probably the biggest barrier, right? There's a historical way of, oh, well, I have a CRM and then I create multiple API connections with those multiple silos of information and then pull the
Mhm.
information in, right? Or I have my data aggregator kind of connected to these various APIs to be able to pull the information in. And so what I would say is right now, what we're realizing is awareness is probably the biggest blocking mechanism is folks just don't know that this interoperability is here, and there's ways to facilitate that outside of what they're used to, which is having all of these siloed systems that ultimately then have to collect
Yeah.
data to a data aggregator.
Hmm. So if you could redesign specialty access from scratch, what elements would you keep and what would you get rid of?
So if I could redo this in the access piece, parts that I would keep would be I would keep the what we've advanced to with BI or with BV and PA support. I would keep that. I would keep it, but I would actually have it more within the billing process rather than it being a step in the flow,
Yeah.
right? And I
Hmm.
think we might see something like that in the future. But if I could put that in the communication protocol with payers for billing for the service for the drug, that to me would be the way that you would then streamline this a lot faster if you had that part of the process. That's what I would keep, right? So I would keep the BV, the PA support. We've come a long way. I keep those pieces, but just kind of put them in the process a little different. Parts that I would kind of do away with. I'm kind of beating a drum here. I would try to do away with anything that's manual paper or fax in the process and make sure that that's not something that we see anywhere near access or specialty access. That's something I would completely get rid of day one. And I think we probably could do that pretty easily if I was if I was designing it. I think I could probably do that pretty easily because I think like we have systems. We need to get more people using the systems and get away from the
Yeah.
actual paper.
I guess this is kind of a tangent, but for trying to get people off of fax, providers, they do what they do. They're really busy. They have like a
Mhm.
million things going on.
Sure,
Even changing your fax number is a huge lift sometimes. So
sure.
I guess your thoughts on, let's say we had this perfect solution where they could, click a button somewhere and everything would just magically appear for the patient. Getting them to actually do that, what do you think are the challenges there?
So this might be controversial to say. I think as we have some of the older generation leaving the workforce, leaving some of the roles, I think we'll see further adoption of technical and automated solutions rather than a traditional paper fax or paper document that gets filled out. It feels a lot like Eesha when, and I was part of the Relay team that was working on seeing providers move away from using paper prescriptions for orders that got sent to the pharmacy and seeing providers move to electronic scripts or electronic e-prescribing, like sending scripts through SureScripts. I remember that. And you saw a lot of the newer physicians that were coming out of school, nurse practitioners coming out of schools were adopting that technology a lot faster, moving to that a lot faster, rather than the old school physician that had been doing paper prescriptions for 30 years. And so I think as we continue to see more of the older generation that basically starts to step out of utilizing their process, which unfortunately probably has more faxes. I think you're going to see a faster adoption or further adoption, I should say, to using more technical approaches for
Mhm.
how they start the prescription order and how they start the support services for a patient.
Makes sense. So in healthcare, I guess the market tends to converge around fewer platforms. So like unifying infrastructure, that kind of thing. That tends to be the case. Are we headed towards that, or do you think the specialized microservices where there's like, a CoverMyMeds that just focuses on PA, and there's like a RelayHealth that focuses on the BV parts or like the claims parts? Where do you think the direction is moving?
So I'm a little bullish on this topic as it relates to because it was kind of talking a little bit more like we were talking about interoperability.
Hmm.
I think as more of that becomes aware, in manufacturers and what exists from an interoperability perspective, I think you're going to see less and not more. I think you're going to see less and you're going to see more of a unified approach of how the
Hmm.
actual services fit together. And I think that makes sense because I think even in the market, we'll see a lot more specialty medications. You see the advancement of cell and gene. You see continue to see more on oncology service medications. I think you're going to see more and more complex medications, and so I think you're going to actually see less manufacturing, more unified. I should say less vendors. You'll see more unified approach. There'll be a handful of vendors that leverage this type of interoperability process, and it'll be more unified than actually having more microservices. And you've got thousands of various different vendors that actually participate. So I actually think it'll be more unified in the future.
What's the one infrastructure change that would have the biggest payoff for time to therapy?
So if if the PA process is added to more of the billing claim, right? So if the technology advances to the point where that becomes more of the actual communication between when that script is sent as a billing order to the insurance company, and if the PA information and the PA structure is part of that process, and so you have less of a separate outside process to complete prior authorization, I think that
Gonna
could
clean a
be
lot.
a
Mhm.
real quick game changer to improving the time to therapy. Because a lot of the time that's taking today is that the process around of getting the access, which usually centers around the prior auth,
Mhm.
that piece, if that could be more streamlined, a part of the billing transaction. And you can already hear stuff about talking about the providers that have like a gold card, right? Or have with the
Mhm.
payer. They're more
Yep.
recognized payers for certain treatments. If that process starts to be further developed as part of the billing process and it's all incorporated, that would be the piece I think that could change and drastically change the time to therapy.
Mhm. So I think we'll go into this last piece, which is a quick hit lightning round.
Mhm.
So I'm going to shoot off a couple quick questions and give kind of your 2 sentence, 3 sentence answers to them.
Okay.
One belief about healthcare you hold that most people in the industry disagree with.
So I think that this is where I think I get a little controversy. I think that it's more around the operate today. It's more around the operations, that not having the operations built out this right way to getting the patient approved, and less about the plan, the payer coverage. It's more around having the operations built the right way. Some people actually will be on the other side of this and actually be more payer. This is the reason why, the payer hoops, payer requirements. I think it's all about how you set up the operations. That's the part, and I think that's where I'll get a little rub or a little difference as far as difference of opinion.
Capability healthcare organizations consistently underinvest in.
So I I think that they can. I think what I see right now is there's less investment in the tech, right? There's still a lot of manual effort, a manual process, manual people that are working in hubs today, right?
Hmm.
I think tech is the part that they're not investing in right now with a lot of the access and hub services.
Talent lesson you learned the hard way.
So long time ago, I would say the one I learned the hard way is keeping somebody around on your team that you should hurry up and cut bait with. That lesson was learned the hard way because this person unfortunately created more still toxic challenges within our work culture, toxic challenges with working with clients, and really created a lot of extra work. And so learn that one the hard way. But need to need to cut ties with people that aren't, you can see it right away, that aren't necessarily rowing the same direction that we're all rowing.
Hmm. Hmm. That's a big one. Alignment is a big one.
Exactly.
All right. Well, that wraps up this episode. Thank you so much, Scott, for sharing your insights, your knowledge, and some of the ways that, we've evolved in specialty over time. And that's it for today.
Yep. Eesha, thank you so much for having me. Really enjoyed the conversation.